Okay. Good afternoon, everyone. Thank you for joining us on day 2 and continuing to join us for these wonderful panels and sessions. My name is Martha Sanchez. You may remember me from yesterday, and I am the new Director of Health Policy and Advocacy at Young Invincibles. And we're here today to discuss Medicaid unwinding and the end of the public health emergency. And with us, we have a wonderful set of panelists, which I will let them introduce themselves because I know I'm going to butcher the last names of everyone. So if everyone could please introduce yourselves, your name, where you're coming from, and any brief thoughts that you have.
I could start. My name is Sabrina Corlett. I'm a research professor at Georgetown University Center on Health Insurance Reforms. Unlike my brilliant co-panelists here who are the smart people in the room, I am the pointy-headed academic and do not do the great work that they do to advocate for better policies and for outreach and enrollment. But my claim to fame is that I spend a lot of time studying federal rules and regulations. So that's what I'm hoping to bring to the table today.
Awesome. Rhonda, do you want to go next?
Yeah. Hi, everyone. I'm Rhonda Ragambe. I use she, her pronouns, and I'm the Health and Safety Net Policy Analyst at the West Virginia Center on Budget and Policy. I mainly work on Medicaid, and so the unwind is very near and dear to my heart. Since February of this past year, I and other advocates have been meeting bi-weekly to discuss the Medicaid unwind in West Virginia and working closely with DHHR and other decision makers to ensure that our churn is as little as possible at the end of the public health emergency. So I'm really looking forward to learning and talking with everyone today about this issue. And thanks so much for having me.
Awesome.
I'm Stacy Pogue, she, her policy analyst with Every Texan, and like Rhonda, help facilitate advocate coalitions and work groups on planning for the unwinding in Texas. And beyond that, my organization partners with Young Invincibles and other state organizations to try to support enrollment assisters, help build their capacity, help answer questions, help connect people, and program an annual conference for enrollment assisters in Texas. Much of the content this year, which will be focused on unwinding a PHE. So assisters are going to play a huge role in all of that work.
Awesome. Well, thank you all for being here again. And I just want to say to our audience members, our attendees, feel free to introduce yourselves in the chat box and any outstanding comments, but any questions, please put them in the Q&A box. There should be a button at the bottom of your screen that says Q&A, and there you can enter your questions, which we will try to answer before the end of the session. And my colleague Mina will be giving us those questions, reading them out. But to get started, I just want to, Medicaid unwinding can sound, it is not great, but Sabrina, could you explain what it is exactly? Why is this happening? And what does this timeline look like?
Yeah, absolutely. So just to level set a little bit, and many of you are already familiar with the history here, but at the very early beginnings of the COVID-19 pandemic, Congress passed a couple of bills to provide COVID relief. And in one of those bills, they gave states more federal funds for Medicaid to help boost the safety net, because they thought a lot of people were going to be losing employer-sponsored insurance. In exchange for that extra federal money, states are required to keep people in Medicaid, even if they have income or other changes that might disqualify them. And that requirement is in place for the duration of the public health emergency. You might also hear this referred to as the continuous coverage requirement or the maintenance of effort requirement. Now, I've been feeling like the girl who cried wolf for like over a year now, because the Biden administration has now extended the public health emergency. I think we're up to 9 times or close to 9 times. But at this point, most of us are assuming that the public health emergency will end in mid-January. And at that point, that's when states can start to resume doing those Medicaid eligibility determinations. And if they want, terminating people or disenrolling people from the program. States are going to be allowed to take up to 14 months to complete all of these redeterminations, but some states might try to do it a lot faster, because the longer they keep people on their rolls, the more money they have to put out. So I think we'll see some states try to do that process a lot quicker, which means a lot more work for our enrollment assistants.
And who, I mean, so yeah, so it sounds like right now people have been able to benefit from continuous coverage on Medicaid without having to meet strict reporting requirements. When the emergency ends, all of a sudden there's this fear that people will be purged off Medicaid. Who are the most vulnerable populations here to be affected by this?
I'll start, and Stacey, Rhonda, feel free to jump in. I mean, first of all, we're talking a lot of people. The estimates are that 13 to 16 million people will be disenrolled from Medicaid, but that'll vary substantially state to state. So if it's a Medicaid expansion state like California, they're looking at maybe over 1 million people being disenrolled. Might be a smaller number in a small state like Alabama that has not expanded Medicaid under the ACA. The other important thing to know is that populations of color are likely to be disproportionately impacted. And we know that, you know, for example, it's not just going to be because income has gone up. It may be because you didn't fully complete the paperwork, or you moved and the mailing they sent you got returned. And we know that a disproportionate number of people who are disenrolled from Medicaid for procedural or administrative reasons are people of color.
Yeah, just to add to what Sabrina said, a lot of the people who are vulnerable to losing coverage here in West Virginia, our estimates. So the total population of Medicaid enrollees right now is about 631,000. That's up about 120, 140,000 from before the pandemic. And we expect to lose 90 to 100,000 folks, mostly because of those procedural and like paperwork issues. Specifically, Black and Brown populations, children are especially vulnerable, although our CHIP rollover may minimize that here in West Virginia. And then expansion population folks and those who use their Medicaid coverage the least.
Yeah, in Texas, we have today 5.5 million people on Medicaid, and about half of them have renewed at some point during the public health emergency, or they're currently renewed, but the other half, 2.7 million, are going to have to renew in this very short time frame that Texas has chosen. We're not electing the 14 months that we're allowed. And those are the Texans that are at risk of losing coverage, even though most will probably remain eligible. And it's certainly in Texas, it's kids. Almost all of our Medicaid program is kids. We haven't expanded Medicaid. Very few adults are eligible. So what we know from national estimates is, 3 in 4 kids who will lose coverage won't be because they were determined ineligible. It'll be these procedural denials or administrative denials. It'll be because they missed one step, right, in the process. The application never got there. And, Sabrina already said it, Rhonda already said it, it's children of color that will be particularly impacted. Our Hispanic children and Black children are going to be much more likely to lose coverage, even though they remain eligible.
We, in our opening remarks today, and I think you just mentioned it, there's this difference between states that have expanded Medicaid and have not. Can you talk a little bit more about that? For example, Texas is not an expansion state. Like, how is that going to affect these populations?
I'll give you one example of how it will impact that, right? Because we don't have in Texas or non-expansion states, we don't have a lot of eligibility for adults. One population who's maintained coverage in the public health emergency has been people who are on pregnancy Medicaid. So postpartum moms, for example, somebody who gave birth a while back, but it's had their coverage maintained. It is possible when they lose Medicaid eligibility at the unwinding, some of them could qualify for marketplace coverage. But in Texas, a whole bunch of people who had Medicaid for pregnant women will actually fall into the coverage gap. They'll be uninsured. There'll be no category to move them to, no coverage that they're eligible for. And I don't think you'd see that same, sizable population having no coverage options at the end of the PHE in states that expanded Medicaid.
So it sounds like a nightmare that is brewing here, in terms of most vulnerable populations, communities of color, low-income families, potentially losing health coverage and being kind of left on the limb here. What should the federal government, what is the federal government doing? Because we know that we've constantly seen a postponement of ending the public health emergency. A lot of that has to do with the fact that it is such a harsh transition to get rid of these flexibilities for people. And so the administration has just constantly been postponing and postponing this. But apart from that, what is the federal government doing? And what do you see is happening at the state and local level that's happening in preparation for this unwinding?
Well, I can start with some of the federal updates, and then welcome Stacey and Rhonda talking about what their states are doing. So first of all, in terms of the timing, the Biden administration has promised states that they will give them at least 60 days notice before ending the public health emergency. So technically the public health emergency is supposed to end in October, mid-October, but because there was no 60-day notice, that's why we're all assuming that it will be extended for another 90 days to mid-January. But in terms of preparations, they have provided several rounds of guidance to state Medicaid agencies. As I mentioned, they're giving them 14 months to complete all the processes. And I think part of the reasoning behind that is if the states sort of work with deliberate speed, there's going to be a lot less mistakes than if they're trying to rush the process. Also, it allows you to spread out renewals so that you don't have a big bulge in later years. I think they're also trying to do a lot to facilitate transitions between Medicaid and the marketplaces for folks who are eligible for that marketplace coverage, and trying to improve what we call these account transfers, where data is transferred between Medicaid and healthcare.gov. And then, of course, many of you probably heard, they have provided an unprecedented boost to navigator funding, because I think they know that navigators are where the rubber meets.
So I'm curious on there are so many fronts here that are moving parts, because Sabrina, you just touched on the importance of navigator funding through people on the marketplace. So are there what are the roles of the state governments and local governments here as well, or are we leaving it just to kind of the federal government to put the funding out there? Are there any other sources, moving parts to this?
Is that a question about navigators specifically or enrollment assistance specifically?
Mm-hmm.
I can only speak to the Texas experience, but so in Texas, we have a large number of navigator grants and a large number of amazing navigator organizations. We also received, organizations in Texas also received recent Healthy Kids 2022 grants, used to be called CHIPper grants, to do outreach enrollment in Medicaid and CHIP. But our state does not have state level grants for enrollment assistance. We have a program that kind of trains enrollment assisters to use the enrollment website and system for Medicaid. So it provides some like training and capacity support, but it doesn't provide any funding the way that the federal grants that come into Texas for Healthy Kids and for navigators do.
Gotcha. Rana, in West Virginia, are you seeing any collaborative efforts across the different state levels and federal level to kind of bring the navigators in on this more?
Yeah, so here in West Virginia, the Navigator program is pretty robust. In the last panel, Jeremy Smith spoke, and he he leads all of that, which is incredible. In terms of, I guess, like intergovernment, like facilitation and collaboration, there is a lot of that. I can't really speak to the details in terms of state funding. But to get a little bit back to your first question, I think like for our task force, we've been working really closely with various groups, including our state health agency, the managed care organizations, the navigators, other folks, bringing them all into the space to really get a sense of what's happening in the state, what different groups are able to do, and just working to support all these different parts. And the navigators are a really huge part of that. I think we expect to lose a lot of folks, and part of that will be folks who are just no longer eligible, and our navigators are really working to mitigate the gap there. We don't have a coverage gap the way that Texas does, but I think still one of our big concerns is that folks won't uptake marketplace coverage and no longer have coverage. So the navigators have been working really, really hard to make sure that they're included in these state and federal conversations, and doing a lot of outreach as well ahead of the end of the public health emergency.
Yeah, I might just add, these transitions from Medicaid to the marketplace for people who do become ineligible and have, but are also eligible for marketplace subsidies, that's just going to be so critical. We know from before the pandemic started that only 3% of people who were found ineligible for Medicaid but eligible for marketplace actually enrolled. So we're losing 97% of the people whose accounts are being transferred over. In terms of states, there are also, of course, a number of states that have their own state-run marketplaces. I am a little bit more optimistic about how the story will unfold in those states, because I think many of them are really, really working hard to improve their cross-agency coordination and smooth those transitions. And some of them have even automated the whole process so that all you have to do is check a box saying, yes, I want this coverage. And so it really reduces the burden on consumers to keep that continuous coverage. So I'm a little bit more hopeful about how the state is.
That's really interesting, because I come from a state where we run our own marketplace. And so it's interesting to hear how in those states, because I guess they have kind of more skin in the game when they're running their own marketplace, that they are more hands-on in terms of trying to have their health departments play a role in making the transition of the information as smooth as possible. Are there any, as you guys are kind of working on this issue, what are your advocacy priorities here? What are you advocating for to make this process better?
I'll start. So we have a few prongs that we're hoping to use all together to just holistically reduce churn. So beyond just bringing all the decision makers and stakeholders into one space to support each other, we've also been working closely with DHHR on some administrative and procedural things that we think can help reduce churn, like ex parte renewals or the automatic renewals. West Virginia has a very, very, very low rate of that. And we also have an understaffed agency. And so That's one way that we hope to reduce churn. And also just expanding on some other administrative things like telephonic signatures and coordinating with SNAP and things like that. But in terms of our advocacy right now, because the can has been kicked down the road so many times and we don't want to jump the gun in terms of notifying folks, we've mostly been focusing on updating addresses because we know a lot of people have moved and have experienced housing insecurity throughout the pandemic. We want to make sure that their paperwork reaches them because otherwise you simply cannot fill that out. And we know that as we've discussed, I think all of us have mentioned that the procedural losses from this period are really the main concern as opposed to eligibility. So we're also working on consistent messaging across different organizations, whether it's DHHR, our navigators, or other advocates to make sure that the message is simple and that it is consistent across different groups. We want to really provide a unified front and really pulling in different groups for that. Our MCOs are really the ones who are doing a lot of the advertising and the outreach. The DHHR is, providing a lot of data and resources around their comms plan, around the populations and stuff. And we're doing research as well as coordinating all of these things. So I think that all these different groups have a role to play in all of this, but just having a very united front has been really helpful for getting questions answered and starting that outreach.
It's very similar in Texas. I don't want to repeat a lot of that, but we're also starting underwater with a significantly understaffed eligibility system, eligibility workers in Texas. I assume that's true in lots of states, but one of our most urgent asks is trying to get the funding needed to just get current applications and current renewals processed in a timely manner. And then beyond that, trying to boost those data-driven renewals that Rhonda talked about that will really take some burden off the eligibility workers and off the eligibility system and helps parents too, right? Helps people too. And we've also tried to build that same big coalition that Rhonda's talking about in West Virginia, because there are so many stakeholders, hospitals, doctors, health plans that are very, very interested in making sure this unwinding isn't chaotic.
And in those outreach efforts, we talked about those vulnerable populations, people of color. I think, Rana, you mentioned the importance of making sure that people are updating their addresses. It's something so simple, but can you talk about how on the ground, how difficult that can be when you're communicating with communities that are marginalized, that may not have much agency or resources to kind of stay on top of these just administrative burdens now that they have to think about?
Yeah, so West Virginia did renewals throughout the pandemic, which I think was a really, really smart move. I know some states halted those, but doing those throughout the pandemic has hopefully mitigated some of that churn. But we know that Medicaid populations, especially ones who fall off of the rolls, are chronically very, very hard to reach. And the people that you're most likely to reach are those who are engaged and have already done the updates and are not really at risk of losing their coverage. And that's one of our biggest challenges is reaching those folks. We've been working with folks who do direct services. We're pulling in pharmacies and different, just hopefully working with not only different points of the healthcare system, but also with organizations that work alongside them or where these populations overlap. And that for West Virginia, a lot of Medicaid enrollees are also enrolled in SNAP, and we have a really robust SNAP coalition. So partnering with them and other organizations that are on the ground already doing this work and just trying to augment their efforts has been our main strategy. But if anybody in the chat has any suggestions for how to better reach people, I'm always looking for those suggestions because they're so hard to reach, it's often hard to conceptualize how to best reach them. So I'm always, looking for new ideas, but we're just trying to have as many points of contact across the state among advocates and direct service providers to get the folks who are hard to reach most of the time.
Stacey, I don't know if you have anything to add to that in terms of communities in Texas.
No, our strategy is very similar. We're trying to work with, let me start with our agencies put out some good outreach materials, but is not, it is making them available to everybody, but doesn't have a very robust outreach plan, isn't going to engage heavily in texting, is really looking to direct service organizations to try to do that. But I think that, if there is a silver lining there, it's that trusted community messengers is what we always find is the most effective way to reach communities, particularly the hardest to reach ones. For example, kids and mixed immigration status families, right? We were losing those kids in Medicaid before the pandemic in Texas because of fear and misinformation. And so, we've always partnered with groups that are working in communities and working with immigrants and providing culturally competent, linguistically appropriate, information. And so that's our strategy too, is that we need to get the materials and the information to the groups who are working directly in those communities, and navigators and enrollment assisters are a big part of that, but there's another universe of groups that are also trusted in those communities, and we want to get the word out through them.
I'm curious because there are so many different players. It seems like there are state agencies, health departments that are playing a role here. Because they usually manage their Medicaid programs and are supposed to be in charge of the outreach and everything. But are you seeing any collaborative work with the insurance companies that will have their plans? Open enrollment is happening. I mean, are they kind of involved in trying to push people to know that this is happening and they know that they have options? Is that a good collaborative effort that you're experiencing, or are you? I'm just curious.
Yeah, so I'll let Stacey and Rhonda talk about the experience in their states, but the state-based marketplaces that we work with, I think a lot of them really are partnering with the Medicaid MCOs. And I mean, the good news is that a lot of the plans that are in Medicaid are also offering coverage on the marketplaces. And so, there's not like perfect match of the network provider networks and other things benefits, but they are certainly motivated to try to keep those enrollees kind of and keep them from drifting away. So I think they are eager to partner, and for folks that are in states using healthcare.gov, I think they can be important allies in this.
Yeah, I totally agree with Sabrina. Our coalition includes the MCOs, who are the managed care organizations, who are also often on the marketplace. So whichever way it goes, they have a stake in reducing churn and making sure that folks who are no longer eligible roll over to the marketplace. So they're very involved and invested in the efforts here, and they have been really great, specifically around using a lot of their funding for outreach and advertisements, including things like billboards, social media campaigns. They've also done postcards and other mailers to get folks ready for the unwind. So yeah, they've been a really big part of the work that we're doing, and have supplemented or taken charge of various things that the department doesn't have the funding or the capacity to do.
Gotcha. The chat is now popping in with questions. I will remind people to please put your questions in the Q&A box. We're going to start going through them soon. But this does remind me, so what are some, best messaging, right? When you're trying to educate people about if they know that there has been changes in their income, if they know it's coming, that they're not going to be eligible anymore. what is the messaging that you all are thinking about in terms of letting them know that it is affordable? There are affordable plans out there. And I'm thinking especially now with the American Rescue Plan subsidies, how is that, how are you finding that you're best able to like communicate that message when the concept of premiums can be so new to folks?
It's a big challenge. I think that getting a new insurance plan can be really overwhelming for folks, especially if they haven't been fully engaged in doing their renewals and different things like that. But you mentioned the ACA subsidies will be extended. I believe it's for the next 3 years. And that will be huge for folks. A lot of West Virginians are eligible for $0 premiums, and most will pay less than $10. So I think just making it a little bit more tangible. I feel like sometimes the marketplace feels like a spooky, like third option, or, you know, just a little known option. But that is one of our greatest concerns, is that folks won't roll over to the marketplace even when they're eligible. So a lot of the work that we do around Medicaid is also story collection. And we interview folks and share their stories about various health topics and issues. And I think uplifting the ACA ones, especially throughout the pandemic when those subsidies were increased, can really show people how useful it can be and how helpful it is, and the importance of having health insurance, because I think a lot of healthy folks would forego that. But if it's affordable, if the services that they receive are as good as those on Medicaid, I am hopeful that people will roll over to it. So we're still working on the messaging. I think we're still in the first phase of just updating your contact information. We are afraid of jumping the gun on all these things because the public health emergency, I think Stacy said 9 times, or Sabrina, I'm sorry, 9 times over the past couple of years, which I think as advocates has also been a little bit, it just makes advocacy a little bit more difficult. So we're trying to take small chunks at a time, and just making the marketplace, just showing what it can do.
I think Rhonda's point about, oh, sorry, go ahead, Stacey. No, I think Rhonda's point about staging, thinking about the communications in stages is really so critical, right? Because talking to people about marketplace premiums and deductibles today is not as helpful as telling them to update their address. If they get a notice from the Medicaid agency, to make sure they, don't wait to open it. Make sure they're ready, to respond to requests for information. Like that all seems to be like, that's where the focus should be. And then it's when they, it's later on, then you want to start talking about the benefits of the marketplace. The only other point I wanted to make is there are a lot of differences between a Medicaid plan and a marketplace plan. And it's not just premium, it's stuff like cost sharing, deductibles. And the networks might be different. And so, there's also the communication you may need to do with people around formularies, like if they're on a particular drug and they really need to stay on that drug. So there's that piece as well. But I think for now, Rhonda's exactly right. It's all about just make sure the Medicaid folks know where to find you. And when they do, make sure you respond right away.
Yeah, the only other message we're using now, and I agree, we're using the stages, we're talking about addresses, but the other thing that we're encouraging all enrollment assisters and all folks to say in their outreach right now is if you get your renewal notice now, because just like in West Virginia, Texas has continued sending them, oh my gosh, renew now. And when we're talking to assisters, we of course explain what you want is your clients to get out of that log jam that'll happen possibly in January, February, right? Where Texas is going to try to renew 2.7 million people in a very short period of time. Anybody who renews now gets moved, gets 12 months of coverage and doesn't have to get put in the log jam that will happen, possibly January, February. So that's the other thing that we're emphasizing is update your address. And if you come up for renewal, complete it. Complete the renewal, get it done now.
And that kind of brings me back to, things that we should be advocating for. Because there is the outreach and education, like you said, stage 1 of communications, just making sure everyone kind of knows what's going on and why it's so important to renew now, to update their address. But then going back to the state agencies and officials, and the federal government, in terms of how do we make sure that the states are able to renew these Medicaid, review them in a timely fashion? Can we talk a little bit more about the importance of that administrative side of aspect, and anything that we should be asking our state legislators specifically for?
I'll start, and maybe Sabrina should start because of just the federal overview. So actually, I'm gonna let her do that. It just makes sense.
Well, I think the good news is that this is a very high priority for the Biden administration. I mean, I think they really recognize the risks of dramatic coverage loss. And I think they are doing what they can within the boundaries of their authority, and the fact that they can't require Medicaid agencies to do, I think, everything they want them to do. The one thing, if you're for state level advocates, one thing I would really love to see advocates ask for is a lot more transparency and dashboarding, so that you can see in real time what's happening, and then you can, if advocates and policymakers and others can see in real time what's happening, you can target solutions. If you're seeing big log jams and stuff like that. So, and that's not something the feds can require state Medicaid agencies to do. And by dashboarding, I'm meaning, like weekly or monthly reports on wait times, and call center capacity, and where people are going. So that's one idea that I would.
Yeah, I agree with all of that. I think that data is so important, and a lot of states, including West Virginia, are not very granular or transparent about like the details of Medicaid. We get monthly numbers and it's just a top line figure, and that's all we have to go off of. But I'm hoping, as we continue to collaborate with them, that they will not only collect but share more detailed data. As far as the federal government goes, I would like to see states, or the government, and Sabrina, please tell me if this is legal or not, but just seeing, I think there's so many discrepancies in how long states will take to unwind. As Stacy mentioned, Texas seems to be committed to doing a shorter one. Somebody in the chat mentioned 9 months. I know West Virginia will take the full time that we're permitted, but depending on the state you live in, unwinding is going to look very different. And I think the federal government can play a role in evening that out. If they have 14 months, I hope that they will take it. Part of Build Back Better, which unfortunately my senator had a role in destroying, had a step down of the federal match, and that would have encouraged states to unwind and take the whole time. While I know that that's not on the table anymore, I think some version of requiring states to take as much time as is allotted, I think will decrease the strain on folks who are enrolled, on the state agency, on the people who actually do the renewals, which in West Virginia is not enough people.
Yeah, Rhonda, I would actually say that the provision that was in the Build Back Better bill that sort of had a ratchet down schedule for the unwinding, I wouldn't call that dead yet.
Okay.
I think there's a possibility that can be revived. So
I would love to see that. On the state level, administratively, as I mentioned earlier, we're working on administrative things like ex parte renewals, increasing that rate to match some of our neighboring states, telephonic signatures, and just increasing the collaboration between the MCOs and DHHR to share information between the two. Oftentimes the MCOs have better information than DHHR, but they can't override anything in the system, which can just create a lot of confusion and a lot of missed opportunities for getting information to the right people in the right place. And then beyond that, I've seen some states do like a pink letter campaign for their renewals, which I would like to see just as something that's visually like just captures the attention of people. There are a lot of little things that I think states can do, the federal government can do, and that advocates can do. And hopefully all of those things work together to ensure that this whole process goes as smoothly as possible.
Unfortunately, I think we're still highlighting just the, bit of chaos that's going on, because some states are encouraging renewals, have been allowing people to renew, others are not. And so I think a lot of our attendees are obviously trying to figure out their role this enrollment period, but then also, for states where people are just not going to really realize whether or not they can renew their Medicaid this enrollment period, maybe not until January, end of January. What is some information that our navigators should just know moving forward?
Well, I'll tell you one thing we've been mentioning to navigator groups, and navigator groups have been mentioning to us, right, is how to work in open enrollment, which is a huge body of work, how to work in steps that also contribute to a good unwinding. And one of the things folks have brought forward is like the ability, if you're helping a client and it's parents, you can ask, wait, do you have kids in Medicaid and CHIP? Because they might, right? Be in the marketplace and have kids in Medicaid and CHIP, and say, hey, right, let me get you signed up for open enrollment, but let's, before you leave, also check in the system, the Medicaid system, to see what address they have, because we don't know which address they have. Let's look at it. Let's see if you want to update that. You have the app downloaded on your phone for, the Medicaid and CHIP application portal. Do you know how to use that? So a lot of the ideas that advocates in Texas and enrollment assisters in Texas are talking about is how can we both give all of the client service we need to in open enrollment, which is a huge body of work, a huge effort, right? But align some things that make unwinding a little easier, and because they might happen, right back to back.
I think that's very helpful. I'm going to go ahead and open up the Q&A because I just have a sense just from the activity that we may have a lot of questions. So Mina, could you start us off?
Yes. Hello, everyone. We do have some questions. So first question, I think one of you mentioned that 90% of people who are found Medicaid ineligible do not enroll in marketplace coverage, even if they're eligible for subsidies. Why might that be? And can we expect that to maybe change?
Well, I can start. I think there's a number of reasons. And first of all, that data is from before the pandemic. And the estimate is that about for people who are terminated from Medicaid and their accounts are transferred to the marketplace, only 3% end up enrolling in a plan. Now, before the pandemic, a lot more of those folks faced a premium for a marketplace plan than do now, thanks to the American Rescue Plan and Inflation Reduction Act. So we have a lot more people today with $0 premiums in the marketplace than they did before the pandemic. So I think that is an area where we can improve that 3% rate. The other issue is just awareness. And again, this is where like navigators and outreach and, health plans and all hospitals and all those partners really can help, is just making people aware of the availability of the marketplace coverage. And then the third piece is just what we call like enrollment friction. Because what happens is, as enrollment assisters know better than anybody, right, is like you come back to healthcare.gov and you got to fill out a whole application and you got to provide documentation that you don't have, an offer of employer coverage. And like, it's just a lot of steps where people have to go through. And they're dealing with 100 other things. So I think the biggest reason is probably affordability, but then there's also just a lot of awareness and administrative burden that goes into it as well.
Great, thank you. We had a comment in the chat and I kind of wanted to clarify with you all, but some states you can't renew early. It sounds like your states are doing rolling renewals where people can do that now rather than wait. But is it the case that maybe other states don't have that opportunity? They have to wait until unwinding starts.
That's right. I don't have a great count, but I know that a number of states, their Medicaid agencies have completely suspended all of the renewals for the duration.
Awesome, thank you. Can someone, this was thrown around a little bit, can someone explain what ex parte renewals are?
I'll do that because I keep saying it. So ex parte renewals are automatic renewals. They take tax data and other federal databases for income to match against, and just verify income information without having to have a person take the form, fill it out, and send it back to the agency where a person would have to confirm that for them to continue their coverage. It's when their renewal comes up in the system, it would just match against this data. If it's over the limit, then they would get mailed a renewal form and they would have to go through that process of verifying their income. But if not, then folks would just continue to get covered, which in a state where we are so understaffed and people are so busy, I mean, I think that's nationally, this can be a huge time saver and just reduce the number of interactions a person needs to have with the agency, which can create churn.
Awesome, thank you for that clarification. Another question, this might be good for Rhonda and Stacy. What are some best practices for reaching people who may not have a permanent address, like farm workers or people without homes and the unhoused?
Oh, do you want to go ahead, Rhonda?
It's okay. I've been talking a lot.
Oh, I was gonna say, I don't think I have one that builds beyond making those connections now and building those relationships with the groups that are already in the communities working with unhoused individuals or with farm workers. At least that's our strategy in our organization, in part because it's difficult to be a statewide organization in a state this big, right? That our strategy has always been to partner with the local groups and the hyper local groups that are serving communities and are trusted in those communities. But Rhonda might have something more detailed.
No, that's exactly what I was going to say is, yeah, partnering with people who are already doing that work and supporting them and helping them build their capacity. And then reaching out to the places where folks would be found, whether it is farms or homeless shelters, soup kitchens, other organizations that serve them, and making sure that we understand the regulations. I know in West Virginia, you can use an address of a shelter that you've stayed at to have an address on file. So just understanding the details of how Medicaid impacts those communities and expanding the capacity of groups that are already doing that work.
Great, thank you. That's really helpful. Kind of along the lines of outreach, but with messaging, do you all have any idea, or at least is anyone looking at what kind of messaging is going to be more effective in terms of like scary messaging or welcoming messaging? You know, you might lose your Medicaid, renew it now. Or do you guys have any ideas or opinions on what might work best there as far as messaging around it?
Well, I'll defer to Rhonda and Stacy for the most part, because this is outside my expertise, but I was just able to listen to the results of some focus groups on this issue. And one of the biggest takeaways that I had is do not talk about the public health emergency ending, because that is very confusing to people and it gets caught up in questions about, is COVID really over? Is the pandemic over? So the general advice from these communications expert was to avoid using that terminology and instead just say it's time to renew your Medicaid, or just be aware that Medicaid is renewing, as opposed to talking about the end of the PHE. But I should defer to Rhonda and Stacey's thoughts here too.
Yeah, I totally agree. I don't like creating more questions in things that we're supposed to be utilizing to do outreach for. So we don't want to include language around the PHE. I think scaring people is the wrong way to go about this. We are trying to create a sense of urgency in our messaging without creating too much confusion or chaos. And I think that's a delicate balance that we're still working on. But since we're still in the early stages of this, we are still working around updating addresses, which feels a lot less daunting than like this whole public health emergency is over. So that's where we're at right now. I think as we continue, we will start targeting our messaging a little bit more for whatever stage we're at. But our primary goal is to convey a sense of urgency rather than like fear.
Great, thank you. More of a basic question. Should people who are losing their Medicaid, do they need to pay attention to open enrollment, or will they get a special enrollment period when they lose, if they lose their Medicaid?
Yes, they get a 60-day open. But that 60 days goes fast, so yeah, they will have to move quickly.
Great. Another question. Is this unwinding impacting just people in expanded groups, or is it also applying to, pregnant people, age disabled, blind groups? Is it everyone or just certain groups?
I was going to let Stacey take that.
I think it's most groups.
Yeah.
I can't say that it's every single group. I'd probably be proven wrong. It's most groups are going to have to renew if they don't have a current eligibility period at the end of the public health emergency. That's certainly true in Texas.
Yeah, it's similar in West Virginia. I think it's probably a similar story nationally. I don't want to speak for everyone, but I think it's important to think about and understand how the unwind will affect non-Magi groups. And that's something that we need to make sure to consider as well. Yeah.
Great. Just a reminder, if you do have a question, please put it in the Q&A box. For now, I think we just have one more question unless someone adds one. But enrollment assisters are continuing to do Medicaid applications as we speak. So should they be talking about this with people while they're enrolling them, or will those people still have 6 months or a year before they need to worry about it? What's the timeline there? What should assisters be telling people as they're currently enrolling folks?
Good question. It's one I haven't gotten before, but I assume in most cases people will get a 12-month certification period. The thing we can't ever answer is how long the PHE is going to last, right? Because maybe all of us would have predicted it. It wouldn't have lasted this long. But I think it's my assumption that I would talk about, you need to report changes when you have them. This is how you do it. You need to renew again at the end of this 12-month period, if that's what you're getting as a 12-month period of certification. It's my assumption, this is an assumption, that the PHE, if you're just enrolling somebody today, that the PHE unwinding will happen in the middle of their certification period, and they'll have a regular renewal at the end of it. But those are just assumptions. We don't know. But at least in Texas, where again we are sending out renewal notices every month and have almost been doing that the entire time. I wouldn't talk to a client in terms of like PHE and unwinding if I was enrolling them today, but I would talk about their how to report changes and when to renew and how to get help with those things. But anybody jump in if they got a different opinion.
No, I think that's what's going on.
think we've got one more question here. Could you talk about reaching people on Medicaid who are currently or chronically sick or need meds monthly, who might be motivated to have coverage via the marketplace versus relatively young and healthy people who think they can go without coverage?
I think folks who are in that population are likely going to pharmacies often. They might have a long-term care person or see doctors regularly. So making sure to educate those direct service providers, I think, is one way of making sure that we reach them and equipping them, as Stacey said, with the knowledge of like just all these different pieces and how the unwind will affect their coverage. And also making sure that they are connected with a navigator. A lot of our state advertisements and outreach will include navigator information so that if someone's no longer eligible, they'll know exactly where to go and how to renew and different pieces like that. But yeah, just casting as wide a net in terms of providers and advocates as possible and creating as many points of contact for people, I think, is really, really important. So just meeting people where they are is a cornerstone of our strategy.
I also, just a real quick, I know we're running out of time, but I also think for an advocacy opportunity, your state departments of insurance can require marketplace plans to provide continuity of services, continuity of prescription drugs. So for example, they can honor step therapy approvals that were made by the MCO or formulary exceptions. There's a number of things that your DOIs, your departments of insurance, can require of marketplace plans to ensure that these individuals don't lose access to in-network services or drugs that they rely on.
Awesome, thank you. That's all the questions we have. Martha, if you want to wrap it up.
Yes, well, thank you everyone for all of your expertise. I keep referencing that this process is chaotic because it just simply is, just basing on the feedback we've gotten from our navigators of how different states are just handling this very differently. But the advice that you all have provided is, I think, will be very helpful, especially when just focusing on what's on the now, what we can do now to support people. It sounds like making sure that people are updating their information and are just aware, but not too frightened about what's happening, because it's a step-by-step process that will hopefully be a long transition for most folks. But I think this is all just very helpful for our navigators to have. And I was just thinking right now, because when we first started this, we had someone in the chat from Florida. And so there's a lot that's going on right now. If it's not the pandemic, it's hurricane season. So there are going to be a number of states that are really having difficulties. So I would hope we keep pushing this unwinding. There may never be a good time for it. And I think that, like you all said, advocating right now for more state resources on the administrative side, advocating for more transparency, so that everyone, all of our advocates know what's going on and what to be asking for. And then eventually knowing that we are going to have to gear up for a lot more health literacy when it comes to informing people of the differences between Medicaid and moving towards paying premiums and deductibles, and making sure that they have coverage for their chronic conditions and medications. So this is going to be an ongoing conversation, and I hope that, at YI, we can continue to partner with you all step by step on how we manage these communications. But I thank you all for your expertise today and for just being helpful. Thank you. And take care, everyone.
Thank you.
Thank you.